All right, looks like we're live. So this is assignment 5.1. I'm going to go into the discussion. Frank Barnes is a 47-year-old truck driver who was admitted to the medical unit at DRHA. He shared a room with Kenneth Lister from Module 2. He was in a room with Mr. Lister for 1 day and then released to go back to work. After he was discharged, the laboratory reported that they had isolated M. tuberculosis complex with a clinical specimen. Infection control personnel reviewed the EHR and observed that there were skin assessment notes about red lesions. Due to the recent increase in bedbug prevalence in homeless and other transient patients, the hospital is required to identify and report the possibility of an environmental infestation. So what we need to start with is, we'll start with going over, we need to develop some steps that we would take to using the NEDSS to report to the state and national CDC surveillance system. So who wants to start with that?
I can start. I found an online participant manual from the CDC regarding TB surveillance data training from June 2009. And I also found a 2001 article in the Journal of Public Health Management and Practice titled National Electronic Disease Surveillance Systems. And between the two, I was able to determine the kind of steps that they were looking for. The first thing that they suggest is that a provider fill out what they call a report of verified case of tuberculosis, RVCT for short. And that report is based on lab data, as well as the provider's information and diagnosis. So according to the CDC, for purposes of surveillance of a case of TB, it's defined on the basis of lab and/or clinical evidence of active disease due to the M. tuberculosis bacterium, and it's not used for suspected TB or latent TB. So it's actually comprised of 3 parts, and the first part is done right away. It's the RVCT, and they fill that out on every verified case of TB. And it's completed as the information is gathered from the patient, such as lab reports and medical records. Then the second part is the initial drug susceptibility report, and that's there's 2 follow-up reports, and that's the first follow-up report. And that's completed after culture is positive for the M. tuberculosis complex. And that information includes genotyping information as well as the positive culture result, and that's completed when the susceptibility test results are received. And then the third part, the second follow-up, is a case completion report, and that's done much later. That's usually done, well, they say no later than 2 years after the initial RVCT. And so that includes treatment outcomes, and also it's completed after the treatment ends so that the completion report can be given. And so those reports are given by our facility to either the local or state health department. And because TB is a nationally notifiable disease, it's then reported to the CDC.
I think that's a pretty thorough run through. I think that's great. That's more than I had on it. So I think that could be well incorporated. I mean, I noticed going through here, I was able to go to the Arizona Department of Health Services, at least from my area. I know it doesn't apply to you where you are, Dave. But they through the funding, if you read the NEDSS article that we or NEDSS article that we had in our readings. They offered grant money to create these programs, and at that local level, it's actually called NEDSS, MEDSIS. So I imagine that's where the initial report would go, and then from there, their responsibility is to carry it further to the national level, from regional to state to, eventually again the CDC, who can then do their research, publish their articles, and make recommendations based off of that.
Okay.
This is Lisa, by the way. I was looking through the CDC's website, and I found the NEDS or NEDSS section, and it was stating that to be NEDSS compatible, the states need to have an informational system that where the disease data entry directly through an internet browser. They need to have electronic lab reporting so that the labs are able to report directly to the health department. The integration of multiple health information databases in one, and then electronic messaging capabilities so that they can share information efficiently with the health department at the local and state and national levels.
Okay. So what I got, Lisa, was the electronic lab report and EHR database, and then what was the third one?
Basically, they need an internet browser, they need electronic lab reporting, they need multiple health information databases in one, and electronic messaging capabilities.
Okay.
Yeah, I think we talked a little bit about that a couple weeks back regarding the incentives and things like that to develop electronic, the healthcare records and things like that. So that seems very feasible in that sense that you would have that technology.
Right, that's true.
So, okay, so what I got, Anne, from you was basically the provider initiates a lot of this, correct? In that they have all the documentation.
Yeah, they suggest that this information come from the provider because that person is probably best suited, to have all that information available.
Okay.
But it can also be done, by the lab, when they get a positive, TB result as well.
Yeah, I also saw that it mentions, collecting that data, from the record anyway, and then they compile that, and that's also sent. And then, if you look at the schematic on it's page 46 in the NEDSS article, if you follow the schematic, it looks like all of that is then kind of compiled into one data. So I think all of those little things kind of come together.
Yeah, I did see that as well.
Yeah.
Okay. So I think that's pretty good. I think Anne kind of hit that one right on the head as far as the steps to using this program. Does anybody have anything else to add on that?
Well, Lisa reminded me that I don't think we all introduced ourselves for this meeting.
Oh, that's
so, I'll just say that I am Anne.
I'm Craig.
And I'm
Lisa.
Dave. And I'm Dave, last but not least.
Our humble host.
A little out of order, but that's okay. Okay, so the second step. How does the surveillance system that NEDSS uses contribute to safety and decrease potential spreading of infectious and environmental diseases?
Well, I think it helps streamline the process because right now, or without the NEDSS system, there are multiple surveillance systems for individual diseases, such as one for HIV/AIDS, one for TB, one for et cetera, So because there's so much separate data, it could be fragmented. So with the NEDSS, the information can be electronically linked. So of the variety of surveillance systems, facilitating timely, accurate reporting that can help analyze diseases for prevention and control. And I found that information in an APHL Management and Information Systems article from 2002.
And I read about something similar to that too, Lisa, streamlining the process, and also the Department of Health and Human Services talked about allocating assets correctly depending on where the biggest need is, so they know if it's a rural or an urban setting, how many resources to allocate to which area.
Yeah, I also saw, speaking of the resources, I really enjoyed that reading the transport drivers transporting medical patients, the research review on that guy. And so now that you have the resources, it's kind of like, what do you do with them? I think it keeps you safe because you can contact those people, you can interview those people because you have their information that was sent, enough information that was sent. You contact and get them treatment. I mean, in that case, 38% or 3 of the people who started the treatment actually completed it. However, having that database and that knowledge on that expanded group of people kind of helps with that herd immunity almost, keeps people safe, so they have that at least on the record and they're aware of it, so when they go to their healthcare provider, they get a positive TB test, they have a little bit of a history behind it rather than waiting. You know, us as healthcare workers get them somewhat often. My hospital system stopped actually doing them yearly, but you get them regularly. So you know, we know whether we have it or not, but people like that, especially people who are having regular trips to a physician, you know, they're immunocompromised, things like that, they're at risk for something like this, for these diseases that are opportunistic. So allowing us to create that database and cross-reference and pull from that, I think we can get the treatment that you guys are both referencing from the other study.
I think that's a great point too, and I think that would be a list that would need to be generated for the hospital. Is what are our higher acuity patients? You know, the immunocompromised, the young, the elderly. What would be our list of patients that would need the priority in this? I think that would be something that we would need to generate as well.
Yeah, and did we make a mistake? Did we miss something?
Mm-hmm.
Did we, you know, how did they get put together? How did we know? Did we do all the stuff that we could do screening-wise before those 2 people got put together in a room, rather than one or the other in isolation?
Mm-hmm.
Yeah, there's a book by Wiley Publications called Concepts and Methods in Infectious Disease Surveillance, and it was edited by Ninanatha and Iskander. And they bring out a couple of other really interesting points too about how this information can be used. And they talk about being able to identify multi-state outbreaks. And you know, we've seen that with other things such as, you know, contaminated produce. But it can also help monitor public health trends such as the effectiveness of vaccines and antibiotics, as well as antibiotic resistance. That kind of information is going to be really important as well. And they even talk about being able to export data that the CDC could use about non-infectious conditions such as lead levels, which could help with environmental health programs and that type of thing. And one other area was being able to identify areas that need further studies. So there's a lot of stuff that can be done with this information, and I think it's a really good program.
Okay. Did anybody else find any other ways that it contributes to safety other than streamlining?
No, everybody hit a lot of the points I had too, besides what I said, so I think we're pretty much on the same page. I think we saw a lot of the same stuff from the research.
Okay. Okay. Are there privacy issues related to this program?
Yes.
Yes, I agree.
Let's see. Well, I mean, just going off of, you know, the points that we made previously, you know, being able to contact people, having that conversation. Obviously, they had to get their names and numbers from somewhere. So these get stored in a database. You know, are people comfortable with that? I mean, you do in this case. You know, as much as with HIPAA, you try to prevent names and regional locations and things like that from being attached to data that you may research. The problem with this is that's not necessarily going to be the best for prevention. So you have to have this name and contact information attached to a part of the medical record so that people have to, you know, suddenly get a call one day, hey, we think you've been exposed to TB, or we think you have, you know, been around someone with bed bugs, maybe, you know, what's going on? Like, you want to talk about that? And, you know, they may not want to talk about that. So, especially getting kind of possibly blindsided too. And beyond that too, just the randomness of the outside agency, maybe not getting contacted by their primary care physician. That's kind of the case with the last, the transporter driver study. These people got contacted and interviewed out of nowhere. So it's kind of convoluted almost in a way. Do they feel violated? And how long do we keep this information? Who gets it? We kind of have a process to go all the way up to the CDC, but I know a lot of people would be uncomfortable with that. And again, how long do they keep it? Where does your information drop off, and they keep you as a statistic, essentially. Just maybe just a hospital statistic. Of how many people in this hospital rather than you personally.
Well, I found some information about that, actually, and it was in the CDC's online participant manual again, the TB surveillance data training from June 2009. And what the instructions that they give is that the case numbers that they send are not to include any personal identifiers. So the local patient identifiers, the local entities will have that, but the CDC instructs those entities not to use names, initials, social security numbers, addresses, telephone numbers, or any other kind of information that could identify the patient. So they have provided an assurance of confidentiality, and the information on the RVCT forms and in the TB surveillance databases that would permit identification, they would be held in confidence and not released without the consent of the individual.
Oh, good. Thanks. That answers my question. I didn't see that. That's awesome. At least on the CDC side, that's good. So it just stays local. That's at least a little more comforting.
Yeah.
Yeah, I was also reading on the Pennsylvania Department of Health website that public health information is exempt from HIPAA regulations because of the severity of things of public health issues. But there needs to be security and encryption of the data. So as Ann said, there doesn't include identifiers. And the public health staff at the Pennsylvania Department of Health can only view information based on their program area, such as infectious disease or such as that, and then geographic jurisdiction and permissions. So they can't see everything. They have their locals that they can see. They can't see every information.
I found some more specific stuff from the Association of Healthcare Journalists in 2014, and they spoke to disclosing the age, the gender, general location, the disease breakout, and then what public officials had learned from the case so far. And what I found was interesting in this is that depending on where you live, if you live in an urban or rural area, rural areas, if you give a general vicinity of where somebody lives, there might not be anybody else living out there but that person. So you have to be very discreet when you put out that kind of information, because it could isolate and identify somebody. So, but they were very, very succinct in what information was conveyed, so that people's privacy was maintained.
I think that would be any of those. You guys hit on a lot of the great stuff that I was concerned with. I think it would be important to find a way, for patients to be communicated that too. I think that's helpful, or at least initially, if they get contacted or brought back in for positive results or communication-based stuff. Make sure they know that too, because it would be. I was just thinking as we go through that, and of course we know a little bit about HIPAA, and you find out a little bit more about how states do it. But most of the general population wouldn't. They get a phone call. It's like, what? How did that happen? Like, wait, I'm kind of shocked. I'm confused. I might have TB, and but you knew about it somehow, like with this ever-seen eye, and so I think that's important to let them know.
Yeah, that's a good point.
Sorry, just writing notes.
No worries.
Any other privacy issues we can think of? Anything else? Okay. So the last question is discuss how keeping track of TB and bedbug outbreaks is beneficial and the value of a national surveillance system. Anybody want to start this? Anybody find anything?
Well, you know, both TB and bed bugs can increase in prevalence and pose a public health threat. So, you know, tracking the spread of TB and bed bugs can help keep the problems more isolated and lead to early treatment and stop the spread. And I did find an article in the Journal of Public Health Management and Practice that points out the benefits of having a national surveillance system, such as improved efficiency over paper reporting, obviously, improved identification of and response to disease outbreaks, as well as better availability of data resulting in better public health policy making.
Benefits to what, Anne? What did you say? I'm sorry.
Which point? The third point?
All I really got was it can help isolate cases and prevent the spread of disease. And then the benefits were what?
Oh, improved efficiency over paper reporting.
Okay.
Improved identification of the disease outbreaks, as well as improved response to the disease outbreaks.
Okay.
And just overall better availability of data that can be used for public health policy making.
Okay. Okay.
Yeah, I think that hits on a little bit of what I said, even more specifically too. You know, just in the way that we treat these conditions, kind of looking at it, you know, with this as our case study and seeing what happened with these two patients and the exposure from one to another. You know, just due to the speed of which we can test these samples, it may change a little bit how we treat the conditions as we look to the numbers and we look to the CDC's data from these reports. We can take away, you know, the prevalence of some of these conditions or things that affect people that can be spread from one to another. And it also, with that, you know, multiple organizations working towards the same sort of the same goal of preventing it. Again, we work, you know, as a community to lower the incidence between all that, using that knowledge that they have to track it at all levels. Thankfully, we can isolate it regionally with, you know, like the NEDSS stuff in Arizona, you know, from that Department of Health Services. And then take it to a larger scale and see, well, how is this affecting the nation? Are people traveling? Where is it going? You know, is this getting worse? Do we need to change travel screenings? Things like that.
And to piggyback on that, Craig, I found some information on the CDC that spoke to that within a region, and we can identify if there's a prevalence in a certain region and there's not in another region. There's also that education opportunity, whereas, hey, what is Idaho doing to control bed bugs because we have minimal cases while Arizona has a ton? What are we doing that's different? And we can educate each other from that. Thought that was pretty cool, sharing our successes and our failures.
Yeah, hey, it's a great place to start discussion, and then you can base it off of the data, which is much better. You know, which is essentially our goal, is to, you know, use evidence-based solutions rather than you know, just skepticism or random hypothesis here, random hypothesis there. So.
I was going to say a lot of the same things that you guys just said, but I did find an interesting number from the CDC's weekly report from March 2014 that in 2013 there were 9,588 new TB cases. And I just thought that number was kind of shocking because I didn't realize that TB was still around so much. So that's an interesting number to me. So having tracking would be, obviously, what all you just said, would be able to eliminate the diseases.
Was that active cases, Lisa?
It just said new cases.
New case, okay.
Yeah, that's a really high number. I'm very.
Yeah,
That's what I was thinking.
Wow.
And that foreign-born persons had a 13 time greater incident rate. And this is in the United States, obviously. So having a surveillance system to be able to track, like you guys said, the who gets it and the prevalence can help that dwindle that number down each year.
Yeah, I think it helps them to, target their interventions to, specific populations. So I think that's another benefit of this surveillance program.
You know, something that just came to my mind is I wonder if we tracked it from like state to state nationally like that. I wonder what the states that allocate less money to public health or to like health departments for this kind of stuff. I wonder what the difference is from state to state. You know, if you have one state that doesn't get quite as much money, do they have a higher incident than maybe a poorer state or a smaller state or a more lesser population state? I don't know. I think that'd be interesting too.
You could look at it like a per capita number, maybe like, how much per person are we spending in each state on public health, and does that change? Though, the demographics of a lot of states will change too. I mean, there's going to be a lot more transplants in some states, people from outside the country, like Lisa said, who have that exponentially higher incidence of TB, for example. How does that change, and are they responding appropriately with spending? I'm not really sure. I could even think of an algorithm that would, per capita spending relative to the number of, transient or transplant or migrant population, whatever it may be. That would be kind of difficult to put together and compare. I would think. I don't know. Maybe that's just me.
Yeah, I think there's lots of things you can do with this information. So it's a really good program.
I guess I was just thinking something like if you took like New York, for instance, or even on a state level, where you look at New York City, where if TB were to break out in New York City, you'd think it'd have a lot more impact on such a large population than perhaps in the rest of the state.
Yeah, living close together too. Yeah.
Yeah. Could it affect how you spend your money? I don't know. I'll read about that. Okay. Is there anything anybody else wants to add? Did we miss any pieces? Is there any additional information that anybody can think of?
I'm good. I think we hit on a lot of good stuff.
Yeah, I think we covered it pretty thoroughly, and that was as much information as I was able to dig up on the questions that we were addressing for this meeting.
Me too. Okay. Well, if everybody's good, then I'm going to stop the broadcast.
You want to do a summary?
Sure. Good idea.
Just so we know what we talked about a little bit. Make sure we hit it all.
Okay. So for step one, I have basically that the provider's going to fill out the documentation, and he's going to drive a lot of this. There's going to be an RVCT filled out on every single case, and then there's 2 follow-up reports. The local state will report then federally to the CDC. We also went in and talked about how each state is different. Arizona uses the NEDSS system, and that system is local reporting that reports to the federal level. Some of the information, the electronic lab report, the EHR database of information, and it needs to have internet messaging capabilities. Sound right?
Yeah, sounds good.
Okay. For number 2, we basically hit on streamlining the process to decrease the potential. Allocating resources appropriately, how does that look? Would it be the immunocompromised, pediatrics, healthcare providers, and then also looked at some screening tools related to sharing rooms when you don't have private rooms for all your patients in the hospital. Is there some screening that needs to be done prior to that? Number 3, the privacy issues, contacting people, what information is conveyed, how long do they keep that information. The CDC goes in and says that no names, initials, addresses, or anything that could identify the patient. They basically use age, gender, location, disease, and what the public officials know about this disease and the spread at this point. Fair to this point?
Fair, very good.
Okay, this last but not least, the last question, how is the tracking of bed bugs and tuberculosis beneficial? It can help isolate cases and prevent the spread of the disease. Benefits, improved efficiency, identify diseases and the treatments of those conditions, the prevalence of conditions, isolations within the region, sharing successes and failures between states, areas, and allocating resources. And then we went on and talked about basically the active TB cases right now. That's what I have. Anything else to add?
Sounds good.
No, I thought it was a good summary. I think that hit all of our major talking points for sure.
Right, I agree.
Okay. Well, if nobody has anything else to add, then we'll call it a week.
Sounds good.
Thank you, guys.
Thanks.
Thanks.
Thank you, guys.